Hello everyone and welcome to our YouTube channel. Today we will continue our speech about the musculoskeletal disease and especially focusing on rheumatology. We covered several topics before. We covered the gout, we covered the non-steroidal anti-inflammatory drugs, we covered the corticosteroid, we covered the rheumatoid arthritis. In this session today, we are going to speak about osteoarthritis. We are going to approach that from the definition, the pathophysiology, the etiology, the risk factors, management of the osteoarthritis related to the non-pharmacological approach and pharmacological approach. Okay, let's get started. Okay, osteoarthritis. Osteoarthritis considered like the most common uh, type of or form of arthritis, and characterized by breakdown of the joint cartilage, and this will make the bone rub to each other against each other, and this maybe breakdown of the cartilage and the bone rubbing against each other. This will lead to the joint stiffness. I'll go back to this lead to joint stiffness, to pain, loss of movement of the joint, overgrowth of bone. All these we can see it on the osteoarthritis. Osteoarthritis considered like degenerative joint disease, and the prevalence, and by 2020 they found like 11.6 million Americans suffer from osteoarthritis, and they estimate that by 2023 we are going to see around 67 million person will suffer from osteoarthritis. Okay, let us discuss the pathophysiology of osteoarthritis. As you can see here, we have cartilage destruction. We have cartilage destruction here, and this will lead to the increased vasoactive peptide enzyme and destruction of aggregate by the proteolytic enzyme. This one belong to the protein, will be destruction protein, and lead to the destruction of aggregate, and this patient will lose balance here due to the breakdown on the cartilage. The space between the joints will be narrowing and suffer from deformity. We can see some microfractures, some newborn formations. We call this one osteophytes, and we have two type of osteophytes. We have Hebertin, for example, and then we have Bochard nodes. Then we have synovitis, inflammation. All these may be related to the osteoarthritis. Number one, cartilage destruction. Number two, destruction of aggregate, losing balance, narrowing space, joint space, microfractures, osteophytes, synovitis. So we are going to bring one image from the YouTube and in less than 10 seconds or 20 seconds to explain what happened in the joints. This from Khan Academy on YouTube, and you can see here on the slide what happened on patient who suffer from osteoarthritis. We have the joint mice and we have osteophytes. Then we have bone polish here. So what happened here? You can see the small pieces of bones here in the on the synovial fluid. What else? We have the narrow spacing between the joints. We don't have enough space to move freely. Osteophytes, we have Bochard's nodes and the proximal pharyngeals, and we have Hebertin in the distal interpharyngeal joints. So we have some maybe characteristic of bone. As you can see here, we have cartilage destruction, we have narrowing space. We have seen that. We have seen the osteophytes, and we have seen the synovitis. So all these considered like pathophysiology of osteoarthritis. Okay. Risk factors here, we are going to see it very often in a patient, for example, above 50 years of age, in obese people, for example, especially when we talk about knee and hip, we are going to see the osteoarthritis, some occupation, for example, that require repetitive motion, such as some athletes, for example, suffer from knee or like hands arthritis. traumatic injury, women more than men, and so you can see it here. We have some risk factor we can deal with. For example, we cannot change age. We can recommend patient to decrease weight. Here we recommend patient to change occupation if they have or they able. Traumatic injury such as car accident. Here we for gender we cannot change anything, so we cannot modify gender, for example here. Okay, moving to the osteophytes, we in the on the YouTube you have seen that distal interphalangeal joint. We have proximal interphalangeal point, and we have seen the osteophytes as a bone growth outward on the edges of the fingers. Okay, the patient suffer from clinical presentation here. What are the signs symptoms here for the osteoarthritis? Pain they occur due to the motion or movement. If you compare that with the rheumatoid arthritis patient, when the patient wake up in the morning, they suffer from morning stiffness. Here, the pain coming from the movement, not from the morning stiffness. If we have it less than 30 minutes, and the rheumatoid arthritis more than 30 minutes, and this morning stiffness will resolve with the motion and occur at rest here, and this will lead to the limit joint motion. The patient may suffer from cryptus, and that means sounds coming from the joints when they moving under the skin and joint. We have seen hybridine nodes and Bouchard nodes. Hybridine on the distal interphalangeal joint, and Bouchard in the proximal interphalangeal joints. Okay, again for the osteoarthritis, this disease is considered like a symmetrical joint involvement. Could be in one knee, could be in one side of the hip. It's not like symmetrical like RA. So in the RA we have morning stiffness more than 30 minutes. Morning stiffness more than 30 minutes. What else we have? Symmetrical. Okay, we have symmetrical joint involvement there. What about lab tests? We don't have any significant changes, no specific lab test. However, in the RA we have RF, for example. We have anti-citrullinated protein. We have the ANA test. We have the ESR, and we have CRB. So we have a lot of variables in the lab test with the RA compared with the osteoarthritis. Goal of therapy when you have patients suffer from osteoarthritis: number one, to control pain and other symptoms. For example, if the patient suffer, we need to improve the joint mobility, correct and minimize functional limitation and disability. All these considered like goals of our therapy. Control pain. Okay, number one, control pain. Improve joint mobility, and correct and minimize the limitation. How we can interfere with these goals? Number one, we go the non-pharmacological therapy for osteoarthritis. We need to educate the patient how to protect their joint, how to practice exercise. If the patients are from overweight or obesity, recommendation for losing weight. Practice exercise to increase muscle tone. Refer the patient to the physical therapy session for exercise and range of motion that strengthens the muscles. And we have acupuncture, we have thermal therapy, and at the end, the last resort will be the surgery if there is no response for all the process. And this joint replacement or surgery considered like non-pharmacological treatment. This is the reason we have the surgery here. Okay, what about pharmacological therapy? What type of treatment, what type of drug you are going to prescribe to your patient here? As you can see, the goal of therapy or pharmacological approach for this patient will be targeted to relieve pain. Okay, so we need to relieve pain in the patient. What else here? If you have older individuals, And normally we have to take other issue with the consideration. For example, when you have elderly people like 70 years old and they have other conditions such as heart disease or hypertension or diabetes, we need to take all these in consideration when you treat the patient, for example. Okay, medication available here. What medication available for the osteoarthritis? Number one, we have acetaminophen. The first medication we have acetaminophen, number one, followed by NSAID, COX-2 inhibitor. Then we have other medications such as tramadol, number four. Then we have opioid, number five, topical analgesic, intraocular injection, number seven. Then we have adjunct therapy for like glucosamine and chondroitin. For intra-articular injection, we can prescribe corticosteroid or hyaluronic acid. So we have option for that. Okay, so now it's very important step to speak about. Okay, we need to look on this approach and guideline for the patients suffer from knee and hip osteoarthritis, how we can approach the patient here, knee and hip osteoarthritis. First line therapy, as you can see here, first line therapy for hip and knee osteoarthritis, we go with acetaminophen. Here we talk about acetaminophen, oral acetaminophen. So please remember here we have oral acetaminophen. First line therapy. What is the alternative first line therapy? Alternative could be cortisone or tramadol. So the alternative first line therapy, we have acetaminophen. The alternative, we have cortisone and tramadol. Moving to the third one, the second line therapy could be opioid, number one, could be duloxetine, could be the intra-articular hyaluronic acid injection in the joint. And so we have this, we need to remember all these. First step, okay, I will repeat that. First step, first line therapy, acetaminophen oral. Alternative therapy will be corticosteroid and tramadol. Alternative first line therapy, corticosteroid, tramadol. Second line treatment, opioid, duloxetine, intra-articular hyaluronic acid. Okay, moving to the next approach. Okay, next approach here. Okay, patients suffer from hip and knee. Guidelines here, how to treat the patient. Patients suffer from hip and knee arthritis, osteoarthritis. How to treat the patient. Okay, we need pharmacological treatment. The first medication will be acetaminophen. We need to ask ourselves, is acetaminophen contraindicated? Can we prescribe it or not? If the answer yes or no, so it depends. Okay, can we prescribe acetaminophen? Is there any contraindicated? We have no contraindicated. We can't prescribe it. Okay, go and prescribe acetaminophen. So the first case, is there any contraindicated? If you indication, if you have no contraindication, prescribe acetaminophen. Okay, what happened here when you prescribe it? Is that treatment is effective? That's great. Okay, continue therapy. So now we have the approach. We ask about acetaminophen drug of choice. And is there any contraindication, for example, for acetaminophen? If the answer no, okay, prescribe acetaminophen and evaluate the situation. Is the treatment effective? If the answer yes, continue treatment. So this is the first approach. The second approach, okay, if the treatment's not effective or if we have contraindication for the patient here, we have contraindication, we are not able to prescribe acetaminophen. Let me say the patients are from hepatic cirrhosis or like kidney failure. We have a contraindication, for example, here. Okay, we have alternative first-line therapy. Alternative first-line therapy could be topical NSAID, like gel, could be intra-articular cortisone, could be tramadol, could be oral NSAID. But for oral NSAID, we have three options here, or three category. Number one, the patient should be less than 75 years. This is number one. Number two, the patient should has low risk of cardiovascular disease. This is number one here. Number two, low risk of cardiovascular disease. And number three, low risk of gastrointestinal maybe complication. So we have the alternative first-line therapy. So first-line therapy, acetaminophen. Continue treatment. If the treatment effective, continue. If you have contraindication, liver disease, heart disease, okay, go with the topical NSAID. Go with the intra-articular cortisone, tramadol, oral NSAID. What happened if the first-line therapy is if the alternative first-line therapy effective? Yes. continue treatment. If they said no, this is not effective medication, okay, think about opioid. This is second line. So please remember, opioid second line, surgery second line, duloxetine second line, and intra-articular hyaluronic acid the second line. So the second line, first line, first line alternative. Okay, I will type here A, B, C, A, and B. So the first line will be acetaminophen. First line alternative will be topical NSAID, cortisone, tramadol, oral NSAID. Alternative second line, we have opioid, surgery, duloxetine, and intra-articular hyaluronic acid. Someone may ask, what is duloxetine? Duloxetine brand name Cymbalta, and this belong to the SNRI, selective norepinephrine reuptake inhibitor group. This is a group medication belong to the antidepressant. Okay, now we are familiar how to approach patients suffer from hip and knee osteoarthritis. Okay, moving to the next slide here. What happened if the patient suffer from hand osteoarthritis? So when you have hand osteoarthritis, we have different approach here because we have small joints. Okay, now we have two cases. We need to ask ourselves, is the patient come to the clinic less than 70 years old or above 70 years old? If the patient less than 70 years or like 70 years and above 70 years old, okay, first line therapy less than 75 years, okay, we need to look on the patient risk factor. Does the patient suffer from cardiovascular risk factors? If the patient has low risk factors for cardiovascular disease and peptic ulcer disease, drug of choice, I will go with the NSAID such as ibuprofen, for example. I will go with the naproxen, for example. So we have several approach. I will go with the piroxicam, okay, or other medication here. So oral NSAID for low risk and less than 75 years old. What happened if the patient come to the clinic suffer from, for example, peptic ulcer disease, or patients suffer from angina here? What we can do for this patient here? So the patient has hand osteoarthritis and peptic ulcer disease or angina or both. How we can manage the patient here? Okay, let me clean what we have here. Okay, to go to the next step. Okay, here if the patient suffer from hand osteoarthritis, let me do it again. Hand osteoarthritis, and the patient suffer from high risk, this number one. Or we have 75 years old patient, for example, come to the clinic. How we can manage? They said you can prescribe topical NSAID, topical capsaicin, or tramadol. Okay, next step. So you can see here, first line therapy for elderly patient, 75 years old. Go with something topical. Don't prescribe anything oral due to the risk of due to the effect, maybe the adverse effect on the liver and on the kidneys. So to avoid effect on the liver and kidney, to avoid adverse effect on the liver and kidney, for elderly people, go with the topical treatment. Okay. So ask ourselves, when you go with a topical, is this treatment effective? We need to answer this question. If the answer yes, continue treatment. If the answer no, okay, you have patient now. Let me say the patient here come to the clinic like 60 years old, and he has low risk of cardiovascular, and we prescribe oral NSAID, and the medication is not effective. So the alternative regimen to go with a combination therapy between the first and second to first line. For example, I will go with the oral NSAID plus topical, for example here. Okay, what happened if you have the situation here for the 75 years old here, let me say 75 years old patient here, or patient come to the clinic with a history of angina and osteoarthritis. So two cases here, more than 75, or the patients are from angina and osteoarthritis. I will go with the alternative approach, for example here. Okay, combined therapy with two first line agents. Okay, continue discussion about the hip and Knee osteoarthritis, first line therapy, acetaminophen. Acetaminophen, and acetaminophen more effective than placebo in controlling osteoarthritis. Acetaminophen advantages: lower risk of serious gastrointestinal and cardiovascular event. Okay, so again, we have the first line therapy. First line, will go that first line therapy here, acetaminophen. Alternative first line therapy, we have two medication. We have oral NSAID. Okay, and think about topical. We have oral NSAID, and then think about topical NSAID. So we have two things: oral NSAID or topical NSAID. Alternative first line therapy: oral NSAID or topical NSAID. Okay, first line therapy option for the when the patient failed to respond to the acetaminophen, I will go with the oral NSAID. Oral NSAID is like superior in relieving pain compared with the acetaminophen. It's like more effective. However, we need to remember that an NSAID carry the risk of gastrointestinal adverse effect, renal adverse effect, cardiovascular adverse effect. Okay, so sometimes we can use COX-2 inhibitor when the patients are from peptic ulcer disease. Sometimes we can use proton pump inhibitor and misoprostol to reduce gastrointestinal adverse effect. Okay, so the alternative oral NSAID. What happened next? Do you have another alternative? Yes, we have topical NSAID. As you can see here, we go with the topical NSAID as a first line therapy option for the knee. Okay, the patient here we use a first line therapy topical NSAID, like less of medication. Number one. Number two, if you have elderly people, I prefer to go with the topical NSAID. And the study found that topical NSAID provides similar results with lower, fewer gastrointestinal adverse effect. Okay, all these maybe first line alternative. Moving to the, so we have NSAID, then we have cortisone, then we have tramadol. Cortisone could be intra-articular injection, okay, and we have tramadol, central effect medication. Okay, tramadol safe prescribed to the patient, safely can add it to the acetaminophen. So you can add acetaminophen and tramadol together. Okay, second line treatment, we have maybe four medication, three approaches for second line. We have opioid, we have duloxetine, then we have hyaluronic acid. I will go to the opioid. Opioid we have prescribed to the patient who at high risk of surgery or predisposed to the surgery due to the maybe refractory response to other treatment. Opioid may cause nausea, vomiting, constipation, dry mouth. Serious effect could be risk of falls and respiratory depression and the risk of addiction. So remember that, please. Two things we need to remember regarding opioid when you prescribe it to your patient. There's two things. Number one, respiratory depression and addiction. Two important things coming from the opioid. Duloxetine, Cymbalta, preferred second line treatment for the patient with osteoarthritis. This medication, especially if the patient suffers from, for example, musculoskeletal pain, and here we can discuss something else. For example, patients suffer from diabetes, and this patient suffer from osteoarthritis, and we know that diabetes associated with the neuropathy. Okay, and osteoarthritis associated with the joint pain. Okay, and in this case, we know that duloxetine will be the drug of choice for this patient because duloxetine treat neuropathy. Duloxetine treat the muscles and joint pain. So the drug of choice here will be duloxetine. Okay, intra-articular hyaluronic acid. What we mean here with intra-articular, that mean we inject the medication inside the joint. Please remember that. Let me clean it again. It's not easy to write here. We talk about injection inside the joint. Okay, intrahyaluronic acid. Okay, you need to look on the highlight. Injection is not recommended for routine use. Injections hyaluronic acid do not provide clinical improvement. Okay, serious effect could be increased pain, joint swelling, and stiffness. We don't have enough data about the efficacy and risk factor. We have limited data. We need more data about hyaluronic acid and the treatment. Okay, here we have list of medication. We discussed it already. We have acetaminophen, tramadol, opioid, NSAID, capsaicin, NSAID, intra-articular cortisone, and then we have intra-articular hyaluronate. COX-2 inhibitor, we prescribe COX-2 inhibitor here. In this case, another choice to reduce risk of GI bleeding here if the patient suffers from osteoarthritis plus peptic ulcer disease. This is a drug of choice because a COX-2 inhibitor preserve and keep the prostaglandin work properly on the GI system. Okay, so moving what we have here, we have some concern about the safety of celecoxib. For example, here they found if you prescribe celecoxib for long term, there's a risk of maybe cardiovascular risk factors. Here we have to take this in consideration. Topical, we have capsaicin, methyl salicylate, trolamine salicylate, lidocaine patch, diclofenac gel. We go through this approach quickly. Capsaicin, we use it for the hand osteoarthritis, and this will lead to the depletion of substance P from the nerve fibers. And we have some information here. This capsaicin causes sensation of burning, stinging, and erythema. Patient may suffer from maybe some side effect. We recommend patient to avoid eye contact and recommend patient to wash hand after administration. Capsaicin. So the question for capsaicin: which of the following medication used for osteoarthritis by the mechanism of depletion substance P from the nerve fibers? Okay, capsaicin treatment therapy, and because they produce systemic adverse effect. Capsaicin topical therapy is the treatment, and capsaicin provide a therapeutic result within 48 hours. Most appropriate for patients with the hand osteoarthritis. Must be used 4 times per day. So which one is correct? Okay, can you go back here and look what we have? Okay, capsaicin. Okay, we need 2 weeks to see the effect for capsaicin. Okay, 2 times to 4 times per day. Available gel and cream, lotion. Avoid eye contact. All these. So type your answer for this question in the comment, please. Okay, next medication, diclofenac gel or Voltaren. Okay, here on the Google image, if I click on one of these images, you can see the image for Voltaren here, for example. Okay, Voltaren gel here. Okay, Voltaren. And you can read the name. Okay, Voltaren gel, relief pain. Regarding the capsaicin cream, you can see here we have some cream here related to the capsaicin. Again, capsaicin here available as a cream. We have several capsaicin as a cream. Also, we have several medication. Another medication for the osteoarthritis, we have tramadol, Altram ER, extended release, or Artracet. This medication used for the osteoarthritis in the hand, knee, or hip. Could be monotherapy or could be add-on to the therapy. How this medication work: tramadol work on the as a central acting opioid analgesic. Okay, so we need to remember this phrase here. Tramadol considered like opioid, work on the central nervous system. Tramadol stimulate or affect the mu opioid receptor, and they found that tramadol has weak inhibition of norepinephrine serotonin reuptake. Tramadol present similar side effect to the opioid. However, tramadol considered like a drug of choice for patients from a risk of BI bleeding. Tramadol, because tramadol is not associated with the life-threatening GI bleeding, for example. When you have risk of bleeding, we cannot prescribe ibuprofen, for example, here. We cannot prescribe indomethacin or other medication. The most common side effect could be seizures in some patients. Here we can see it regarding the tramadol. Okay. Okay, the luxetine belong to the selective serotonin norepinephrine reuptake inhibitor SSNRI, belong to the antidepressant medication, and this is a considered like a new generation of antidepressant. The duloxetine practice inhibitory effect on the brain. Uh, Patient may suffer here from nausea, dry mouth, constipation, anorexia, dizziness. Here they try to remind us the duloxetine may cause Steven Johnson syndrome and liver failure. We need to look on the Steven Johnson syndrome in the Google image just in case to be familiar with the situation here. Okay. Okay, next medication, or maybe could be the last medication, glucosamine and chondroitin. Glucosamine, chondroitin, considered like dietary supplement. According to the American College of Rheumatology, they have recommendation against using the glucosamine and chondroitin. Clinical trials have some concern about the safety and efficacy of this medication, this complement here, and they found it's like the glucosamine chondroitin present similar effect to the placebo, and we don't have recommendation to use it for the hip and knee. How this medication work? They said supplement glucosamine and chondroitin for regeneration of cartilage, and we have here question mark. We need to be able to figure out, is this information correct? Is the glucosamine chondroitin able to regenerate cartilage? Regarding the dose, we need to look on the dose 1500, 1200 for both, and if the patients are from shellfish allergy, this medication derived from the some maybe some seafood may present a cross allergy between glucosamine chondroitin if the patients are from allergy to the seafood. Okay, moving to the next. Here we have a question, practice question. Which of the following agent is recommended first-line therapy for patients who are from osteoarthritis? Here, first-line therapy: ibuprofen, celecoxib, diclofenac, tramadol, acetaminophen. So which one is ibuprofen, celecoxib, diclofenac, tramadol, or acetaminophen will be first drug treatment for this patient? Let me know your answer in the comment. Okay. Okay, this will conclude our lecture.